Thank you so much, and I apologize for any issues with Zoom. It appears that it did not like me as a panelist, so I will try to make up for it. So my name is Tanaz Boyle. I am a pediatric emergency physician and a health services researcher here at Boston Medical Center. I have been the lead for the Telehealth Working Group for the Region 1 Disaster Health Response System since 2018, when ASPR initially launched us as a pilot program. So it's really my honor to moderate this webinar today. And I'd like to set the framework for our discussion and this really remarkable demonstration of new operational capability developed by our colleagues at the ASPR Disaster Telemedicine Program. Next slide, please, Damien. Next slide. Okay. Have you gone over the webinar etiquette already, Damien?
Not for the group, no.
Okay. Do you want to do that, and then I'll take over the framework?
Yes, ma'am. So good afternoon, everybody, and of course, welcome to the webinar. Just for your information, of course, the webinar is being recorded. The primary method when it comes time for question and answer will be the Q&A feature of the Zoom webinar in and of itself. After we have the ASPR demonstration, of course, we'll have a 15-minute Q&A using that Q&A feature of the Zoom webinar. Within the Zoom Q&A feature, there is opportunity for all participants to vote, to view all questions and upvote questions that you have interest. So if we don't have time to answer every question, we can address the questions that have the most interest. And within 48 hours, a link to the webinar will be sent to all participants, and the recording will be available for a short period of about 30 days, at which point in time we will take the webinar in itself offline. And a sort of quick agenda for the day, a real short to the point, a bit of a welcome and warm up with Dr. of course, Tanaz Boyle. Turn it over to the ASPR Disaster Telemedicine team for a short presentation and an operational demonstration. And of course, as I mentioned, close it out with a Q&A session at the end. And Dr. Boyle?
Great, thank you, Damien. So, what I'd like to highlight here is that over the last 40 plus years, the US government and the military have really advanced our technologic capability to support humanitarian response in difficult to reach settings. Disasters can destroy local health infrastructure, as an example in the Joplin, Missouri tornado. It can displace large segments of the population for prolonged periods, as we often see in hurricane season or wildfire season. It can produce large surges of patients that require specialty care that may be in short supply, as an example, the Maui wildfires. And then more modern threats like cyber attacks can debilitate health systems without really even inflicting physical damage, as evidenced by the Lurie children's cyber attack just last year. Now, while every disaster has unique needs, disaster telemedicine can really serve as a force multiplier because it can augment the medical response by providing rapid temporary access to healthcare at the point of need. If you can advance to the next slide, please. Still, even as we advance our technology readiness, in the United States today, we still lack mechanisms for establishing immediate connection to those clinical specialists across jurisdictions, across state lines, across health systems, if they do not already exist. And so ASPR's Disaster Telemedicine Program is really an important step towards filling this gap on a federal level. Next slide, please. An effective national solution requires some core elements, and I'll highlight three important components here. First, it needs to be flexible to deliver care and to tailor care delivery to the needs of each event. While many solutions have been developed locally, our efforts are often siloed and specialized. Some systems may be retrofitted for disaster use, and so having a standardized system that can be flexibly deployed to fit the need would be a major advancement. Second, it has to be rapidly deployable. We need to be able to care for patients wherever they are at the point of need. And we need to be able to support facilities and health systems regardless of which network they're in. We should be able to leverage our considerable specialist cohorts across state lines and jurisdictions. And in some cases, these services should be rapidly available within hours. This is still not possible today. So again, another potential major point of advancement. And then lastly, we need to have interoperable technology that is rapid and easy to use, even even in the face of physical infrastructure damage. Next slide, please. So the webinar today really is a example of collaboration between 3 ASPR-funded programs: the Regional Disaster Health Response Systems, the Pediatric Disaster Centers of Excellence, and the ASPR Disaster Telemedicine team, as a commitment among our teams to collaborate and share ideas and solutions to building up our national strategic response capabilities. So without further ado, I'd like to hand over to my friend and colleague, Commander Passman, and her incredible team to kick us off on their operational demonstration today.
Thank you for the great introduction, Dr. Boyle. Just in the interest of time, I'm going to try and speed up this presentation part. I'm Commander Dina Passman. I lead our disaster telemedicine program at ASPR, which you may have been hearing about for a while. We're really excited to do the demo today. We also have Amy Keim, our Senior Medical Officer, and Commander Lisa Tung, our Data Scientist. Next. So like Dr. Boyle said, we really need a comprehensive program. And in addition, it needs to be all hazard. So it can't just be critical care. It can't just be pediatric. It needs to sort of have this broad application: hurricanes, tornadoes, etc. So we have 3 goals with our program. One is to strengthen our field resources. We often use disaster medical assistance teams, or DMATs, and our program will help strengthen those teams. Next. Extend our medical capabilities, so we're adding specialties, which helps to extend the cadre of clinicians and gives us an expanded response capability. So we can be several places at once. We have a hub and spoke model, which allows us to help in several different operations at the same time, no matter where they're located. Next. We have a cloud-based telemedicine platform. So there's no native software required for any of the platforms from which you use it, and an integrated electronic medical record system. I already said it's all hazards, so we'll go to the next slide. We do have this disaster-focused EMR. We're really proud of it. Amy will give you the demonstration and the walkthrough. So on the left, you have our tracking board, and on the right is a patient record. In the middle of a remote consultation, we're going to demonstrate that as well. Next. We have 28 different generalists and clinical subspecialties available. I'm not going to go through the list here. You'll get these slides. But as you can see, there's a broad swath of specialties that we've determined are the core ones that we need to launch the program, and eventually we will likely add other ones. Not only do we have the integrated electronic medical record, but we have integrated diagnostic equipment that we can use for real-time viewing and interpretation. So you see we have blood pressure cuff, we have the stethoscope, we have a EKG machine, we have ultrasound, and we can also integrate with the devices you see on the right. Because it's often necessary to know more about a patient than what can be provided on the spot during an emergency. We do have access to major health information systems in the US, which could tell us what medication someone's on, whether they had prior surgeries, any lab results, immunization records, and we have the ability to see that so that we can provide the best care possible. Moreover, we know that people speak many different languages, including American Sign Language. So we have access to over 250 languages. at the disposal of our clinicians. We also have e-prescribing, so we will be able to tell which pharmacies are open and dispensing. We can either give a paper script to the patient, or we can send it electronically to the pharmacy for them to pick up. In terms of connectivity, we have both cell phone and satellite. We have a cradle that can pivot between them as the systems are available in order to maintain connectivity to the greatest extent possible, and with communications in order to optimize our connectivity. And last but not least, we have dashboarding capabilities. So all of the different indicators, all the data that we have in the system can be converted into indicators and visualizations. Those can be customized for command and control at a higher level, at a headquarters level, and then also at a field level. We can customize all of these and create reports. The typical dashboarding qualities that you are likely familiar with. Next. Okay, just one thing before we get into the platform demonstration, which is all those different components of our platform do not need to be used all together. So if someone just needs the HIE, or an operation just needs the HIE, they can use that. If they just need interpretation, they can use that, and so on and so forth. We're going to show you a number of those options as I pass it off to Amy.
Yeah, thank you, Dina. So when we think about telemedicine, we're often very familiar with one where somebody can consult with their provider from home, or a clinician can consult another clinician in a setting where those clinicians may not be localized in the same place. But our program is extremely flexible. It can work in very remote environments. It can be deployed with pre-hospital. It can be deployed in areas where ambulances have yet to reach. Even individuals, if they can get the message, might be able to sign on to the remote provider. It can be used in hospitals from consultant to consultant. It can bring in teams to discuss patients that are being managed in a field hospital or prolonged field management. It can even be utilized to move patients who are almost ready to be discharged from the hospital, but it can create hospitalization at home, so it can actually be deployed to work with patients in their home if they had to be discharged from the hospital earlier than anticipated or hoped for, because we had to make room in a local hospital for incoming patients because of a disaster or public health emergency. It's a very flexible program. And as Dina was saying, it can be deployed with different components of it. It can be deployed just web-based. It can be deployed with our equipment, which includes everything that you saw there, as well as linked to APIs for other groups' equipment. So when you have a question about disaster telemedicine, you can ask, what are the needs? Can we meet those needs? What would that look like? And we can focus on customizing it. It is a highly customizable program. And so what I'm going to do is walk you through what we have in terms of the EMR and the integrated telemedicine. And I'm going to share a screen with you here. Just give me one moment. Okay, so what we just landed on here is the dashboard that gives a real-time view of what's happening in the field according to who's looking at it and what type of imaging they may need to be able to see. Do you need an overview of the types of conditions that we're seeing? Do you need to understand the medical needs out in the community? What types of responses? In this, the first thing we do is set up an event. And when we create an event, this is a little bit different than other platforms and other EMRs, because we have the ability to create our events, but we also have the ability to create different sites in different locations. We map those also on longitude and latitude so that we can see what those look like on our map and the relationship to each other. We add facilities that show us not only where this is located, what type of facility that it is, if it's pediatric, community hospital, community clinic. And then we tag these with resources. What is available at that time at that facility? And what this does is when we're ready to discharge a patient from our care, we want to send them to somewhere where they have the care that they need available to them. So if they need a pediatrics, if they need a GYN, we actually will tag these facilities. And then on the discharge, the provider will pull up what type of facility they can look for. They can search for one that has OB care, general surgery, different types of specialists that are available, and that can be continually modified during the deployment of the system so that we always make sure that our patients are being sent somewhere that is active and can provide the type of care that they need. And then pharmacy. So we are working currently to keep our pharmacies updated with EPAP accepting pharmacies that have been activated and pharmacies that are open. We can even search for those under, I'm going to just use a name brand here just for a demonstration, and search those, pick those up so that, okay, we only have one CVS in Alaska. So that these pharmacies that get added to our list, so when we send out an e-prescription, it's actually going to an open pharmacy, not just the patients, the one that they decide that they want to go to, but we actually can make sure that they're open and receiving patients. Now I'm going to take you to the dashboard. So this is the tracking board. So this is the overall tracking board. Whether you're going to access telemedicine or electronic medical records, it all gets done through here. This is where we register our patients, how we track our patients, what's happening with them. And I'm going to point out a couple of interesting things that we have. We have the typical things that you might expect to find on a dashboard for a hospital. But remember, this one is operational. So we're really just focusing on what we need to know and minimizing a lot of the noise that comes from other dashboards or other EMRs. Patients can be triaged by their disaster triage level, but we also can use ESIs here, so they're interchangeable. So if you're moving from one system to another, these can be modified for that. Coming across, you'll see these little hashtags here. We have privacy settings for patients who are VIPs or responders as well. Let's just go across here. If you click on it, you'll go into the chart, but we also have some other important indicators here. We have icons that can let us know a little bit of information before we go see those patients. They're hearing impaired, they are vision impaired, they speak a different language here. And if you hover, you can see what language that they speak. A lot of times providers are going into rooms, they don't really know that this information ahead of time, and this will really help them move much faster and accommodate the patient's needs more easily. This is one of my favorite features here. We can actually see if the patient is a member of a group, and we can find other family members that are with them. This indicates that this patient has a parent, and the parent is with that patient in the facility that they're being seen, right, as a patient. So this parent is there and they're a patient, but we'll come over here, and this person, there's two other people with this person in the setting. And we can see that these are non-patients. And this is important to know who is with this person, especially when we have minors. We can also indicate that there's an unaccompanied minor here. So we know right away to watch out for this, to monitor this patient very closely. But we can add other people who are not necessarily family members, but in this case, this child is being accompanied by a police officer. I can go into that patient's chart, and I can get information not only on this police officer, but I can have a photo of them as well as their ID. So we're tracking these, making sure that we understand who this child is with, and we can see their ID there that we would take at intake. Right. Going across, you might notice a couple little stars here. We have a very robust way of registering patients very rapidly, and we can assign them their a pseudonym should they need that. And we can also estimate their ages and estimate their weight. So if we don't have that information when we're registering, we can actually put estimates in, and we'll always see that we know that it's an estimate because it's demarcated as so. When we register a patient, we can scan right off of a driver's license with a peripheral scanner or with our tablets. So we can pull that information very rapidly and to do rapid triage. We're setting it up right now so that they can do field triage for MCI events. So they'll just even tag the triage. it's going to create if they have like a triage card on them. So if we can scan a driver's ID and put in their information, but if we don't, we'll identify that patient in the field with that barcode. As the patient moves through the system, we can scan each barcode and tie in each medical record for that patient so that that patient, when they go from the field to EMS to a base of operations for a DMAT team to a hospital where they've got multiple IDs, multiple barcodes, we can link those all to the same patient so that we can watch that patient move through the system and have continuity of records and care. The pediatric, this has a lot of similar features to what you're going to find in your average EMR, including we've got indicators for when we have critical findings here and tags to let us know more information about that patient. So I'm going to take you to one of our patients and show you how one of our consults works. Now we can go right from getting a patient registered directly to a telemedicine consult, or we can actually go in through their chart. I'm going to place a new specialist consult. Let's say I have a lot I can choose from, but I'm going to just choose a pediatric critical care provider. And here's where we decide how urgently we need a telemedicine consult. It's not necessarily based on their triage level, but the need, how rapid this consult needs to be. You can add information, choose video, phone call back, asynchronous messaging. And that's going to bring us into our session. Right now I have some time, so I'm just going to enter the waiting room and I'm going to wait for my specialist. I'm going to give it a minute to connect. Now this is on, there are multiple ways to do this over Wi-Fi. We're going to do this over 4G or 5G. If the connection does not hook up, we'll have a failover where the satellite will pick up. Great, I'm going to move my telemedicine consult in. And we should be joined by the consultant momentarily. Hi, I'm Amy Keim. I am contacting you from the base of operations for our DMAT team.
Hi, my name is Lisa. I'm your pediatric intensivist. How can I assist you today?
And that just gives me the opportunity to proceed with a consult from there. I realized I didn't turn off my mic. My apologies to you all. So if you got a little bit of a feedback there. And I want to show you another way that we can approach this. I'm going to place another consult. And we know that in the field, people can be very busy. You might not actually have time. So this is more emergent. I'm going to actually go see my rest of my patients while I'm waiting for that specialist. And I'm going to return to the tracking board. Now here, there'll be a little indicator. It's telling us that we're waiting for the telemedicine specialist. And I'd like them to notify me when they're ready. So I've just got notification. They can notify me on my phone number, there can be an audible ring, and I can see that there's a specialist ready there. This time I have to mute my mic here. So I'm going to go in and join my call. So I've already spoken to my consultant. Let's move this on. So we have a chat app in the background that we can also talk through. Hi, I'm calling you back about patient Andy Corolla.
Hi again. How is our patient doing?
He's actually doing really well. He's stabilized. We're going to be transferring him over to General Hospital. We are waiting for admin over there. And I'd like for you to speak with an intensivist that they've been able to locate that now is in hospital. Great. Thank you so much. So the point of that being that we can actually bring in multiple people into one call to coordinate the care prior to the arrival of the hospital. When the hospital's in field, we can give sign out to the receiving providers in this way. It's really allows for that communication to freely occur. And also anybody that's brought into this, they can be permissioned to look at the medical records as well, or even go into the documentation. We have a lot of features here and not a lot of time to show you everything. I think that gives you a little bit of an introduction to our capabilities. I just want to also bring up that we have components where we are now looking at epidemiological markers and to help us identify early C-burn events across multiple sites that will also be active on our dashboard. And in our encounter notes, I know this is a child, but humor me, I just want to show quickly that we have the ability to capture some of the information from the field that's really helpful in understanding some of the background on the patients as well as their environment, their situation, and then even exams specific to age groups that we can integrate. So again, very comprehensive. And if this is a touch screen, they're basically somebody's just clicking through on a tablet for these. So I'd like to go back to the group. I think it's about time for our questions and answers. So I'll stop. I'll leave this open in case anybody has any questions about that.
Thanks, Amy. I just wanted to round out by just emphasizing that we do have quite a few pediatric functions in our electronic medical record system, which I know would be of particular interest to this group.
Sure, if you want me to show a couple of other ones when you're within a patient. So this is a patient who's tied to the mother. You can identify that. And let's say even like a little fun one here for any clinicians that are on. I know that when I see some abnormal vital signs, and I always have to go find the person who took the vital signs and ask them, was the child awake? Were they sleeping? So we even have little indicators, our pediatric indicators that they were sleeping during that evaluation, as well as we are able to track according to how premature a child is if their vital signs are within the normal limit for prematurity. Again, I could talk a long time about all the different types of features that we have built in specifically for disaster settings in the pediatric population, but I think it's a good time to do the question and answers.
Thank you, ASPR team. I'm going to stay off camera here just for ease of communication. There are several questions already in the Q&A session, and so I'm going to start with questions that folks have about access. So there's questions about, can this system be available to first responders who are often deployed to a disaster away from their home, and more broadly, how might one access, request, and get access to this program?
Thanks, Dr. Boyle. I can take this one. And unfortunately, the answer is generally disappointing to our audiences, but this is a federal capability that is deployed like all of our various ASPR capabilities. So it does require a declaration, does require the normal request channels that you would go through to get support. So if you were part of that response where there was a mission assignment where ASPR is deployed, then this would be available to all of the various providers who were in support of that response. On that note, there was a question about the platform itself and ownership. So ASPR does own this. We do not currently have any open source code available to our partners.
Thank you. Is there a way post-event that the medical records can be sent to the individual's local primary care provider or for longer term follow-up?
Amy?
Yes, absolutely. So when a patient is discharged, they can actually receive their medical records by email. And they can also, we can forward those to any providers. We're also working on methods in which we can share those records with other systems. Some of those are more complex, but the patient can definitely access their records and pass those records on if they request they be emailed to them.
Can you also talk broadly about who pays for the services once deployed? Is it insurance, the patient?
No, we are not in the insurance business, at least not at this point. So these services are provided just like any other federal medical service. Right now, we happen to have funding to provide a number of these services cost-free to our states through a declaration. Then there's also the mission assignment process where our services would be priced out. But I do have to say, compared to a lot of other ones, we are a good deal.
Can you also talk a little bit about the list of consultants who might be on call? Are they deputized to act on behalf of ASPR, or do they have to be deputized to be on this list?
Great question, Dr. Boyle. I know we have those cross-jurisdictional issues, but with federal providers, we do not have that barrier, which is a big plus for our system. And then contractors who work for us also become sort of deputized, as you said, and covered by federal, the tort exceptions.
There are a couple of questions about identifying pharmacies. So Amy, maybe this is for you. For eScripts and identifying available pharmacies, do you have the capability to identify if the medication is actually available?
So the medications themselves, no. The pharmacies, yes, we are actually working with another organization that will be providing real-time uploads for us in CSV form that we upload into our system to identify open pharmacies. But in terms of looking at their formularies and knowing what's on hand, we do not have that. The medicines that we typically, I think, would request, they would have a way to respond back if that medication was not available and they required a different medication.
There's a question from one of the NDMS team commanders. They're wondering if this system is going to replace the current NDMS EMR.
At this time, no, we don't have any. Our program is separate, so we will not be using their EMR, although they do have the option to use ours with regard to telemedicine consultations.
There's also a clarification question about access, about whether or not state-declared disasters would be eligible or only federal disaster declarations for authorization service.
Yep, just to reiterate, our services are available just like every other federal service. So if there was a declaration where ASPR was supporting a state, then absolutely. But if it's a state declared emergency that is not supported by the federal government, at this point, we are not available for deployment.
There is a question about how would you socialize and train people to become knowledgeable with these systems? So is the system available to a state team in a training environment to learn and become knowledgeable?
Absolutely. Opportunities like this give us the chance to talk to folks about the various capabilities. We do have a training environment, which is what we used for our demonstration. And absolutely, we can work with folks who respond in the field in order to learn all the ins and outs of the system so that they could use it during a federally declared disaster.
Can you also talk a little bit about how teams and providers in the field will be made aware of this resource when it is available?
I'll start, and then Amy, if you or Lisa, if you have anything to add. We've been working on socializing our program across ASPR, so we've worked very closely with NDMS, also in developing the program, and we've briefed our team commanders and our DMAT responders. So, we're working really hard to do that sort of education within ASPR. And then again, because we talked to our regional emergency coordinators about our program, they would bring it to the table when we were defining the requirements and what was needed to respond to the disaster. So hopefully we've covered all of our bases, and it's an ongoing process. So we'll keep going to educate everyone, and so that we're used in the field when we're required.
Amy, can you talk more about how the telemedicine consult discussions and recommendations are documented and maintained in the EMR? Is there, for example, an AI recording of the discussions?
So we are not currently using any AI recordings because of privacy issues there. And we've talked about recording these, but we do not. So they are recorded by the person consulting and the provider, and then the telemedicine provider in separate medical documentation and maintained as that documentation within the patient's chart. We are exploring doing different methods of recordings, but again, there are a lot of privacy issues surrounding those.
There's a broad question in terms of privacy about how your system complies with HIPAA. Can you expound on that a little bit?
Sure. In terms of HIPAA, it's a little bit different during federal deployments through ASPR. We don't have any insurance associated with this, but we do maintain privacy of the patient. So the same factors that you would see in any EMR, you're going to see here. There's two-factor authentication for sign-on. There's isolation of patient records according to their site and event that don't go across those barriers. There are the same controls and fences around this EMR as there would be any other EMR, with the exception that we don't that the system is not just as an ASPR deployed system is not doesn't work the same way with HIPAA compliance in terms of we're compliant, but the same requirements do not necessarily apply. And of course, if it's deployed within an institution, then those institutions' parameters will also be in effect.
I just wanted to also add that our system complies with all of the federal requirements for privacy and controls and security. We do testing every week with our security team, and we do have an authority to operate. So we're fully locked down according to the federal requirements.
Mm-hmm. And within Health and Human Services.
One more question about access under federal declaration. There's an individual seeking confirmation about whether this capability is also available for Puerto Rico and the U.S. Virgin Islands. I presume this is yes, but just looking for confirmation.
Yes, we supported the U.S. Virgin Islands. It was our initial deployment for a cyber event. So, yep.
Has there been any thought about including medical reserve corps or other larger pools of specialists to expand your available consultants?
Yeah, I mean, we've thought about all the different permutations of including providers from across the spectrum. Federal providers are our current focus, and as we get moving on the program and see a need for incorporating other providers, certainly is on the list.
I'm getting signals from Damien that we need to start wrapping up. So if there are final questions, please put them in the chat. Will there be computer training held, and how often might this kind of training opportunity be provided?
Thanks. We don't currently have a training schedule, but we do have equipment that we deploy to the field, as I showed you. So there's tablets, there's laptops, there's the peripherals, and we will be developing trainings and getting out there to train folks as the need arises, though, as I said, we do not currently have a schedule of trainings.
And then I'm going to ask take the privilege as a moderator and ask a vision question. For events that don't rise to the level of a federal disaster declaration, is there a vision for an integrated partnership with other ASPR programs like the RDHRS or COEs to support regional or interregional response, or is that still something that is far away?
Sort of similar to increasing our, access to and incorporation of various providers. We'd love to be able to integrate with all sorts of ASPR partners, and that's sort of part of the wish list and part of what we're going to develop. We're in the, crawl, walk, run framework here. So once we nail down our current program, we will look to expand.
Fantastic. I'm just looking through the list here. There's some more detailed questions that, Damien, can you confirm we can provide this list to the ASPR team, and perhaps some of the more detailed questions about the system can be provided in a written response and shared later to the webinar attendees?
Absolutely, Dr. Boyle. We'll work with our ASPR peers and develop the question and answer responses and include that with the slide deck when we send that out, hopefully within 24 to 48 hours.
Perfect. And so maybe some of those questions like, can you provide an inventory list, how the equipment is packaged? There's some detailed questions that I think would be best suited in that environment. I will say that just scanning these Q&A, people are broadly impressed and really appreciative of this incredible capability and a big advance, really, for our response capabilities.
Dr. Boyle, you may not be able to see Commander Passman has her hand raised.
Oh, yes. Go ahead.
Thanks. There was a question around recording various patient details in the record. We are a federal program. We are subject to all of the executive orders and laws and regulations that are out there. So at this time, we conform to the ones that are currently active.
There's an interesting question here about, can you come with your own equipment? If there are DMET teams who have other users who have devices they'd like to integrate, is that possible?
Amy?
Yeah, so you're talking about communication, so it can be used on tablets, on laptops. If there's our teams deployed with specialized medical equipment that we can load APIs to communicate with that, such as an iStat machine or a Piccolo. Those can be integrated as well. Even looking at a PAC system right now for integration of different types of deployable X-ray units.
Sounds like they're asking about peripheral devices such as medical equipment like stethoscopes and.
Right. It comes with ultrasound, stethoscope, some of that equipment, but if they want to use their own, it depends on whether their devices are capable, and we would have to have an API to communicate for those to be a seamless integration with the medical record.
And to answer another question, those devices are securely packed in, Pelican-like cases and can be shipped to the ground during our, kind of similar to sending DMAT equipment or anything else to the field. And it's customizable, depending on the needs.
There's perhaps the final question. Is there a disaster where you are currently deployed, or can you share a recent deployment experience?
I think that the answer is no, we're not currently operational. Like I said, we did respond to a cyber event in the US Virgin Islands. And we do have a blog post on our ASPR page, which I believe Damien sent a link to and had a QR code, and that was to support radiological readings. So I'll spare you the details. You can read them all by yourself, but we're standing by. As you know, there's a lot of hurricane activity going on right now, and if there's a need, we are ready. Amy, did you have one last word to say?
Oh, no, there was a question that I just wanted to answer about bras, that they saw the color pink next to a pediatric profile. And I just wanted to note one of the really neat, interesting things that I didn't get to touch on was that we have Broslow dosing that's set up so that when you go into a pediatric emergency or critical care, you can actually hit an order set that will immediately reflect the patient's by weight, and that can be overridden too if you want to change the Broslow color. So we have a lot of these built-in features. We have so many features we would love to talk more about, but it's all meant to improve care, the quality of care, the ability to rapidly respond in the field or in any setting with the end users in mind. And that's it.
Amazing. Well, hopefully in another year, we will get another opportunity to see where things are, and if you've had any real world experience or deployments to share, and see if we can continue to iterate on this incredible resource. Thank you so much for your time and your attention. I know there's several unanswered questions that that your team will work on. And Damien, I'll hand it back to you.
Thank you, Dr. Boyle. Thank you, ASPR telemedicine team. Just a quick couple announcements or quick acknowledgements to repeat what Dr. Boyle mentioned at the beginning. Of course, thank you to Region 5 for Kids, the Pediatric Pandemic Network, and the Region 1 RDHRS for sort of come together to sponsor and host the ASPR disaster telemedicine operational demonstration. And so it's going to wrap up the end of the webinar. I thank everybody who stayed long for those additional questions. Really appreciate your interest. We're going to close the webinar in about 2 minutes, 3 minutes. In the meantime, we're going to close the webinar now, but we're going to leave up this slide for a couple more minutes for those that are interested with some of those detailed questions. This is, of course, is a QR code that'll take you to the ASPR disaster telemedicine fact sheet. And with that, Dr. Boyle, any final comments?
Go forth and be great.